Okay, we're ready to start. So the topic of this is, you're going to like this. This is going to be freewheeling, and we're going to take questions, and we have a great panel. The war on medicine, how the media and politicians undermine science. And I'm going to start with the word misinformation, what that means. And then I'll introduce the panel. I'll tell you a little story. Heidi Larson, who's the head of the Vaccine Compliance Project in the United Kingdom for the WHO, I put her on the radio about a year ago, and I was all set to talk to her about misinformation, because that was the going word at the time, and it's the word now, actually, because 2 weeks ago I had Dr. Khalif on, and he talked about misinformation and what the correct science is. Well, first of all, misinformation, whatever that is, I'll tell you in a second, but it changes because the science of COVID has changed dramatically throughout the pandemic. And there's too much gotcha-isms going on. And so so if you stick to the word misinformation, but the science changes, then somebody on the other side that you're calling misinformed will attack you for the science changing. So that's one reason that word is a little suspect. The other was what Heidi Larson said, which is, she said, if I want somebody to take a vaccine, I don't come to them and say, you're misinformed. I ask them what it is they think and why they're reluctant to take the vaccine. And that's the starting point. And I find that in my practice too. Somebody will say, well, it's, a new vaccine. I'll say, no, it's not a new vaccine. It's an old vaccine. And I explain that the technology is from the 1980s. Or it's genetic therapy. That's another beautiful, or it's not safe, but it turns out, wait till they get the smallpox vaccine, right? So it's a lot safer than any vaccine we've probably ever made. And that's how technology evolves. So you go through what somebody's concerns are. It's going to affect my fertility. Well, actually, it doesn't do that. It's safe during pregnancy, and on and on and on. So I don't like the word misinformation because it puts off the very people you're trying to inform. But we're going to talk about that today in a very deep way. You know who I am. I'm a professor of medicine at NYU. Liz Goldberg over here in the middle is associate professor of emergency medicine here at Brown. Associate Professor of Health Services Policy and Practice. She deals a lot with geriatrics. She deals, which is an amazing thing to deal with, which I'm going to bring up. Also digital health. She does a lot with public health. Scott Rivkees is a pediatrician. He's a pediatric endocrinologist. He's a professor of the practice here at Brown. He's a former Florida Surgeon General. He survived that somehow. And
it was a vaccine.
Karen Tashima is a really, really terrific infectious disease specialist here at Brown, trained here, was instrumental in the studies of protease inhibitors in the 90s, which was groundbreaking for HIV, actually changed the world. And I'm going to ask her about that, how as it applies to Paxlovid, because that's a drug that's getting a lot of attention lately. And there again, misinformation, right? Everybody has a theory. What is this rebound? I'm going to ask an expert. What is this rebound all about? Does that mean the drug doesn't work? Does it mean that everybody wants to be an expert during this pandemic? And that's been very harmful. Let me start with Liz on the issue of geriatrics. I have a question. At the beginning of the pandemic, I was talking about cocooning of the elderly, meaning that it was an old tried and true public health measure that you took people out of the way who were most at risk. And we know over a certain age, there's a dramatic increase in morbidity from COVID-19. But doesn't that also speak to us all being in it together? How come we don't understand that if an 18-year-old gets COVID and spreads it to a 90-year-old who's at higher risk? So it's not all just personal choice if the person around you, how come we can't get that concept across?
Yeah, the cocooning has had a lot of unintended consequences. So first of all, many older adults actually rely on caregivers. And who are our caregivers? They're younger folks. And if they're not as careful as our older adults that are homebound or living in nursing homes or living in assisted livings, then really their isolation and all that stress that they're bringing onto themselves by cocooning is not that much of benefit. And also this approach that, if you are someone that has a disability, if you are older, if you are immunocompromised, then just hold bubble yourself up. That is not a public health approach, right? We need people to be outside. We need them to be active. And we've seen so many, I don't want to turn this panel into an episode of Untold Stories in the ER, but as an emergency physician, we've seen so many patients come to us now with falls, with lacking mobility. And the reason is because they were scared to leave their homes. And when you're not mobile and active and interacting with humans, you become lonely, and your level of mobility goes way, way down. And that makes you vulnerable for a whole slew of other diseases, including frailty. So cocooning is not really the public health practice that we want to embrace. And unfortunately, that was one of the lessons learned during the pandemic.
What about, what's your best mitigating strategy for people at risk? And I'm assuming you're agreeing with this whole idea that it's literal, it may be changing with Omicron to some extent, but it looks like the older you are, the heavier you are, the more comorbidities like diabetes. And I'll ask Dr. Rivkees about diabetes in kids in a minute, but.
Mm-hmm. Yeah, so I mean, overwhelmingly, the best strategy now is get vaccinated, get boosted. And if you haven't gotten that second booster and you are older, you absolutely want to get that second boost, because we've now been on a steady increase in cases for about the last 8 weeks. So, and we're also seeing increases in deaths. And it's the folks that aren't recently boosted, aren't vaccinated, that we are seeing with increased mortality, right? The other strategy is we should still be masking indoors, and we should be using rapid tests. It's lovely that we have rapid tests now. We can test before we go to events with people. We can test so that we can travel. That real explosion now in rapid tests is really critical to us moving on a little bit with our lives and living with COVID. But we still need to be thoughtful about when to mask. And number one strategy really is vaccination.
Scott, and by the way, you guys can break in also, you don't need me to, kids that are diabetic, that are at higher risk, I think there's a lot of confusion about vaccines for kids. Talk to us about it. Like, obviously the third shot just got approved for the 5 to 11-year-old group. The under 5-year-old group is being held back because 2 shots didn't work. Dosing, there's questions about dosing. Who should get vaccinated and what should they get for kids?
Yeah, so first of all, vaccines are FDA approved for all children 5 years of age and older. And as Liz mentioned, the pathway forward and the best way to protect oneself is through vaccination. Even though you focused on diabetes, sometimes people have the perception that it's only children with underlying medical conditions who end up getting severely ill. That's not the case. If you look at children who are hospitalized, 60% will have underlying conditions, but 40% haven't had them. And the data are very clear with pediatric that these vaccines are safe, that these vaccines are very effective. And when we see children who are hospitalized during this pandemic, so there have been about almost 13 million pediatric patients who've gotten COVID-19, more than 100,000 individuals vaccinated, more than 1,400 children who sadly have lost their lives. And we see severe COVID largely in individuals who are not vaccinated.
And presumably, and I'll ask you this about, Karen, about my sense of immunity. Again, this is to cut through the word misinformation, is that with Omicron, especially with the subvariants with BA2 and BA 2.1, 2.1, it's the more immunovasive, the more immunity, the better. So the more vaccines, the better. You don't want to have had COVID. And as a matter of fact, it looks like it's where your immunity from COVID is wearing off. There's words out that from South Africa that the BA1 immunity you get isn't covering you too well against the BA4 in South Africa, now Portugal. Anyway, talk to me about what we should do in terms of the best immunity we can get.
Sure. So something like 83% of Americans have availed themselves of at least one vaccination. So that's really great. And I think something like 75% of kids, maybe you can correct me, but have had COVID. So, and a very high percentage of adults have had COVID. So you have this combination of people having had the vaccine, maybe all the doses, and you've had COVID before, then we've had the variants come through. And so the vaccines are, and we have waning immunity from the vaccinations, as well as having had COVID. So then you're susceptible to another infection. It could be it's a different variant. Your immunity has waned a bit from the vaccine. So it is this ongoing situation. And if you've been vaccinated in the last 4 months, then you're going to be protected against getting COVID, but also in a major way against hospitalization and death. So you do want to be up to date with the vaccines, get the boosters when they're available, and so I think it's a combination. Like some people are boosted by having had COVID recently, so your immune system has seen it, and you are probably not going to get it again for at least 3 months, maybe 6 months. And so there's a lot going on, I think, with that.
One more question on that. There's confusion about the Omicron specific vaccine and why it's delayed.
Yeah. So so the vaccines are still effective against hospitalization and death, but maybe less effective against getting the Omicron variant. So you can have these what we call breakthrough infections. So breaking through your vaccine status, and so you can get another one. But they're still highly effective. So even if you've dropped your protection from 95 to 80%, then you're still 80% protected. So it's still worth it. We have right now in the U.S. we have 2 main Omicron variants that are going around. So I wrote down BA2 is 39%, and BA2.12.1, which is the latest one, is about 58%. So we don't test in real time. If you came in and you're PCR positive or your antigen is positive, we don't know which one you have, but likelihood you have one or the other of those. And then that affects, potentially which monoclonal antibody you're going to get. But the treatments are still, the Paxlovid is available. So that will still be effective against those Omicron variants.
I'm going to come back and ask you about Paxlovid. Scott, why is it that, I'll keep going around. Why is it that, from a public health perspective, how come there's such a delay now? Like, in other words, how come Pfizer said they would be able to get us a vaccine for specific variants and pivot in a month, and now it's 6 months? I mean, what is actually going on? If we paid Pfizer, would that help? I mean, in other words, is that the issue? Is on a political level now? What's the delay in this?
I can't comment on the political level or what's going on within the FDA, but for the approval of all drugs in therapeutics, whether they're vaccines, whether there's Paxlovid, it's important that what products get out in the market are first efficacious and are safe. There's a history of products getting out there, and then with post-market surveilling and monitoring, things end up coming off the market. So I think it's really important that people have confidence in the products that they're giving themselves and giving their children. So the way these studies are designed, they're very rigorous. They have to have proper sample sizes. They have to have monitoring. They have to have really important follow-up measures. So I think it's taking that long. But I do want to also emphasize, never in our history have we developed vaccines this quickly. The first, case of Omicron in the United States was January 21st, 2020. And Operation Warp Speed started almost within a month afterwards. And then by December of that year, we actually had vaccines. So even though we want things to happen more quickly, it's really amazing how quickly things actually came about.
Yeah, completely agree with that. Amazing, the public-private partnership. Liz, let's get into this mask issue. That's such a murky area. If you look around this audience, you'll see some people wearing masks, some people not wearing them right, some people wearing right. I'm sorry. But like me not wearing one, I wear one on the way in, then I take it off. And here's another thing. As soon as the mandates go, nobody wears them on a plane, which, by the way, yes, the HEPA filters help you. Yes, the filtration system helps you. But when you're on the runway, so what's going, I'm not a mandate person, but I want to understand, do masks work? Why aren't people wearing them? How come people are half-hearted? How come some people are religious about it? Other people are, what is this? What is it?
So I'm actually on the Providence School Board, and nothing I'm saying here today represents school board opinion, but I'll tell you that I'm still every week having conversations about masks, and we are, over 2 years into the pandemic. And the issue is that people feel that it infringes on their civil liberties, and we have, every school board member, folks that show up that say that provide misinformation about masks and often say masks are not effective, masks are ways to muzzle our kids. Masks, Providence was one of the last districts to drop the mask mandate earlier this spring, and we were hearing from folks that we were purposely leaving masks on our district that is primarily Latino and Black and not white, and that was racism. And the bottom line is masks have been shown to be effective, and sometimes they're also uncomfortable, and that's why we're having these mask wars. But mask mandates work. We have seen increases in cases now that the mask mandates have dropped, and it's highly, highly political on whether you agree with the mask mandate. As a politician, speak up for mask mandates. I think, for instance, what was happening in the South earlier this year, where school boards were really wanting masks on their kids because they knew that we didn't have vaccination yet for kids, but governors were saying, well, we are not going to provide you the state funding that you need to run your district if you, as a school board, have mask mandates, and putting school board members in those positions is really, really, really unfortunate. So yeah, mask wars are continuing. Still getting those calls every week, and I think we're going to see that for months to come.
And I think that the mask mandates had to happen because otherwise you wouldn't have people masking at all, right? So masking indoors or masking on transportation. Same with vaccination in healthcare. So healthcare workers were mandated to get the vaccine, and that was the only way really to get everybody to get vaccinated, so that we could get those high vaccination rates and protect the healthcare worker and protect their patients.
I'm going to throw a curveball on you on that one because I have let me give you a pushback on that. It got a little problematic when the vaccines, which were initially designed to decrease severity, but worked so well that they were decreasing spread. Now you have a situation going forward with the variants where they're not decreasing spread very much, but they are still decreasing severity. And then there's people that have had Omicron, which other countries like Israel and the European Union count that towards a green pass or something. So I don't like the idea of healthcare workers losing their jobs if they had some kind of immunity from some source. Were we flexible enough on that?
Right. No, well, we were not flexible. And, I think it is hard when you're in the middle of a pandemic. What are you going to do that's going to have the biggest impact right away? Did we really know enough about how long that immunity was lasting? We didn't. So, that's what we were faced with at the time. Now we have treatments, we have monoclonal antibodies. I think that the vaccination status is still required. So, but I think it's softened a bit, but it's still, I think, I think you could soften it now because we are much further along. We're 1.5 years past the first vaccines. And also the public wanted to know, is the vaccine safe? Well, if I get up and say I took the vaccine and all my colleagues took it, and we're going to be, we're good right now, we're fine, it's been a month, and let people know that we're ready to get it. Like that's a very important thing.
Hugely important, and a lot of healthcare workers haven't taken it, which is.
Some haven't, but if 98% did, that's great, or 95%.
Why not? Go ahead. This is freewheeling. Scott, you're next after this. But
hi, so I'm just going to take my mask off. So I live in Hong Kong. I'm on my first trip out of Hong Kong in 2.5 years. Part of it is coming here.
That's great. Fantastic.
And, we have to wear masks outdoors. We have to wear masks on public transportation. We have to wear masks in bars and pubs if we're not eating and drinking, a bit like the new rules here. We've obviously had 2 kinds of vaccines. It's gone well apart from the elderly. Okay, when Omicron hit Hong Kong, with all of that masking, within about 3 months, the epidemiologists at HKU reckon that 60 to 70% of the population had Omicron. So I think one of the things that frustrates me, it's taken me a few days of being in the States to not reach for my mask every time I stand up in the chair, right, in a restaurant. If the point of masking is to protect the healthcare system, to flatten the wave, which we think back to all the dialogue we had 2 years ago. We got to protect the National Health Service, got to protect the hospitals, doing all this. People will get sick. We just want them to get sick in a managed way. Is the whole point of this now just to try and stop people getting sick at all? Because they will. The evidence in Hong Kong is that even if you're wearing a mask, even if you're in outdoor groups of no more than 4 people, this thing will spread. So if anyone in this room has Omicron, there's a chance that we'll all get it, right?
Let's not go there. Let's not go there. But I think, that's a valid point. And in the beginning of the pandemic, we were talking a lot about flattening the wave. And we did not have strategies like vaccination, like Paxlovid, like therapeutics to prevent people from getting very severely ill. So absolutely, in the beginning of the pandemic, masks were an important strategy, not only for flattening the curve, but I think also the severity of infection. And we have to think about folks that are double vaccinated, older adults, like you mentioned, people that are immunocompromised. Vaccination might not be enough for them. If you're masking around them, it might, reduce severity enough so that they don't end up, in the hospital or severely ill.
So, my heart was crushed when I got the email on Friday about having to wear masks indoors here, right? And I'm sure that was sent out at the last minute.
I like it. I mean, to me as a physician, masks are nothing. I mean, it's like, that's one of the reasons I brought it up. We wear them all the time. Yeah. But Scott, you wanted to say something. That was a great, thank you for bringing all that up. And by the way, an additional point about this is the zero COVID strategy caused so much damage to the economies on top of that. And then there was a lack of exposure. But then again, we're learning more about long COVID, which is we're trying to avoid. So you wanted to say some things about collateral damage or?
No, I was just going to comment on the issue of saying that we want healthcare workers to the vaccine, but we didn't count prior infection. But this is early days of the pandemic, and this gets into the messiness of medicine and how things are really shifting, which really leads to attacks on medicine, things like that. But early on, we didn't know how protective a prior infection was, what the durability was, but we had information about vaccines. And then people in medicine, it's not just protecting the health worker, but it's protecting the person that my colleagues are seeing and yourself are seeing in clinic. One of the unusual things about this virus is the amount of asymptomatic infection and asymptomatic spread. With Omicron, up to 30% of individuals of Omicron have no symptoms, but can be contagious. So in the healthcare setting, that's a very special setting where we have to protect our workforce, but also protect those individuals we're taking care of. And certainly early on, there really wasn't clear evidence about how long infectious immunity protects you for compared to vaccine immunity. And then even now, one of the issues we know is that if you're infected with one variant, you may not necessarily be protected against another variant. Whereas the way these vaccines are designed, you will get protection against multiple variants. So that's part of those issues.
Great answer. Dr. Siegel, believe it or not, no relationship, in South Africa is looking at this exact issue of how much protection you get from one subvariant to another. By the way, and Scott was famous for, you all know this early on, when we didn't have a vaccine, he was focused very heavily on mitigating strategies. And then the vaccine was supposed to not take the place of those mitigating strategies, but we were all hopeful that it would at least take partial place. But then the subvariants and the variants evolved. So it's changing science. That's why the dogma has put people in a bad place. If you're dogmatic on something.
There's a question.
Go ahead. Oh. Yeah. Great answer, Scott.
Thank you.
I have a question about future pandemics. All right. Now that we know, so back to your concluding comments. All right. So I'm a private practice cardiologist, public health official. Okay. And I deal with a lot of nursing homes. And we are now seeing these elderly patients having just tremendous, decline in their cognitive function, all sorts of things because we really protected them and we protected them just to the nth degree. And I live outside of NIH, and so we were like to the nth degree. was like crazy there, all right? And also our children. So going forward, what types of strategies can we start thinking about? So let's say we have, you know, COVID-2, it's gonna be some other virus that comes 5 years from now. What are we gonna do? What types of things are we gonna have in place for the nursing homes, for the assisted living, for the schools? Because we can talk about masking, this and that, you know, all sorts of things are going on in the country, but let's talk about what's gonna happen in the future so we don't make those mistakes, so that we don't have the elderly populations that now, you know, they can't function, and we don't have school-age children who, you know, are having
Haven't seen
more
Friends.
problems than we can
Yeah.
care to discuss about
Yeah,
right now.
this is,
Okay?
yeah.
Phenomenal
What
question.
are we gonna do going forward? What are your ideas? I'm really curious about that.
Everybody take a
that's-
stab at that.
That's just a phenomenal question, and I think the answer there's two things that we really need to invest in, and the first thing is healthy buildings. You know, we have so many schools in this country that don't have HVAC, and the climate is changing. We're not at the end of this pandemic. There are going to be future pandemics. We need to get HVAC systems that have high-grade filtration into our schools. And the second thing is rapid testing. You know,
Yes.
we did not have a robust testing infrastructure, and we still, you could argue, do not have a robust enough testing infrastructure. But if we could, you know, rapidly test those CNAs as they come into the nursing homes, if we could provide rapid testing to the family members that, you know, have not seen their loved ones in the nursing homes for months on end, if we can provide rapid testing before our kids enter their schools. There's actually these large devices now that can test, you know, multiple people as they enter buildings. That's the type of technology we need to invest in.
Not to be devil's advocate,
Mhm.
but let's say our next virus, all right, is unable to be detected. Okay? Are there other strategies? Like, should we be thinking about other types of things outside of the box, outside of what we would have done with this virus? Okay, so that we can really have more of a structure. 'Cause let's say it's not a respiratory, let's say it's something else. Like, I feel like we have to start thinking about other things and not just use this virus in particular and how it's transmitted,
I just,
but other strategies on how to protect people so we don't, because we cannot isolate people again.
one thing that we're not strong enough about here, and this speaks to your point, is genetic testing. We don't do sequencing enough. The wastewater analysis is terrific. We just started really using that. Your point about testing, you know, one of the things is just common sense. Do you really want somebody to have to go out somewhere to get a test? Well, they could be spreading the virus as they go. So
Right.
the home-based strategy, clinic-based strategy, test and treat is something that took us 2 years to get to. But all of that can be applied going forward. mRNA technology. I think if we could cut through all this anti-vax sentiment, that's a phenomenal advance.
So,
Kids in
I mean,
home are testing every day before they go to school.
Yeah.
After school's just regular. Every day the kids have to show that I'm negative.
Wow.
Karen?
yeah, I think that it's being discussed at very high levels too. Like, what can we do going forward? I'd love to, you know more about what's being discussed. This was obviously this was a pandemic that we haven't had a pandemic since, HIV is a pandemic, but different transmission routes. But, you know, the Spanish flu was many, many years ago, 100 years ago. So I think that, when we re-signed up for an HIV grant that's through the NIH, they said, are you willing to be a site? Are you willing to be prepared for a pandemic? You know, and I thought, wow, that's really, I'm glad that they're asking that question. Yes, we want to be able to ramp up in terms of clinical studies. And so the NIH, did put that question out. That was at least 10 years ago. So that's good that people are thinking about it. But, you remember back when we had bioterrorism, we had a lot of committees and a lot of energy and money goes into that. And then maybe nothing happens for 50 years. So what are people, where do we spend our money? But I think we have to think about it. So
Scott, pandemic preparedness?
Yeah, it's such an incredibly important question that you're asking. So I'm going to, step back. So first of all, pandemics, by definition, they're global. This is actually our third COVID pandemic. We had SARS, we had MERS, and the 1889 Russian flu pandemic was actually a COVID pandemic, and the common coronaviruses we have now are part of this. So what do we need? We need global networks of surveillance. both surveillance of clinical symptomatology where things are popping up, and then all terms of molecular surveillance. If something has genetic material, it can be found and it can be sequenced. COVID-19, we had the molecular sequence by the second week of January 2021. So that's really important. Nations need to be able to work together, in these issues as well. Within different countries, we need to have groups that are followed prospectively so we can know which population is it hitting, how is it spread, is it respiratory, is it contact, is it touch surface to have issues there. And then also, how do we deal with this? Public health really needs continued investment. The funding that went into the part of CDC that went for pandemic preparedness had dwindled over the past decade. And then also basic health care. Why do we have so many people that are so vulnerable to COVID-19? And it gets into health equity issues, so there's so many different layers which are there. But to catch these things early on, again, global networks of surveillance,
So,
countries working together, sharing information.
Let's go a little further into health disparities, because not only was that true in the not only was that true in the United States, but Madhu Pai, and he's not alone, up at McGill has been screaming that rich countries are loaded with vaccines up the wazoo. Poor countries can't get them. They're not sharing them. And if they have them, I'm not talking about medium middle income countries like India. I'm talking about Africa. I'm talking about really poor areas. Not that there aren't poor areas in India, but India has risen to the challenge now. But at the beginning, India was exporting vaccines and their own population wasn't having it. How do we overcome these healthcare disparities around the world that Scott is talking about, and here in the United States? Whoever wants to take that.
Can I ask a question? I have two quick points to make about what we discussed previously. First of all, about masks on transportation. We're a country that's really divided on this. I flew here from San Francisco to Boston, and about 3/4 of the plane were wearing a mask. I met my husband here, and he came from Arkansas to Providence, and he said he was the only one on the plane wearing a mask. So we're in different places. I do want to make the point as to the original topic of this talk. I think our messaging to the public has really been lousy in a lot of respects, and it's not to blame anyone, because we didn't know really what was going on at the beginning. But I didn't hear anyone say we're not really sure what's going on, and here are the facts as we know them now.
Exactly.
And that would have been more helpful. And the way you got in that setting, the way I got patients to get the vaccine who were hesitant was to talk to them one-on-one and explain, I've gotten it, I didn't get sick, my kids got it, whoever, got it. And your family needs it, you have an old grandmother who lives with you. And those kind of conversations could make a difference, but not someone just yakking at them through the TV saying, you have to do this.
So that's a great point, and that's the answer to, instead of saying you have to do this or the word misinformation, the answer is you say the science is evolving, here's what we know now.
Right.
We're humble in the face of the evolving science. Exactly right. What do you think the solution is in terms of global health care disparities and how it's played out over the pandemic?
Well, I think the disparities we saw right here in Rhode Island. So I think that recognizing it is really a lot of the battle, and then trying to figure out, well, what was it? Why were we seeing so many Latino and Black patients in the hospital? And was it they were truck drivers going back and forth to New York or things like that. So I think that it was really important to try to understand why that was, and socioeconomic differences, disparities have been talked about a lot over the years, and we can do better. We can do more. So
I think, on the equity point, I think what we realized way too late into the pandemic, on your point also, is that we really need to rely also on trusted messengers. There's experts, folks on this panel, physicians, scientists, but we're not often the best at translating exactly, this clinical trial data to something that, the average human understands. And so there can be trusted messengers, religious leaders, people that do Latino radio, people within like the AARP community that are trusted by older adults. And really what we should have done is much more outreach to those folks and let them disseminate within their communities, like really locally. And I think we realized that too late, and that's why we saw some disparities in the uptake of vaccinations by racial groups and ethnicities.
One great example is the Black community's distrust of the medical establishment that goes back
Right.
hundreds of years.
Very
And
legitimate
I talked
distrust.
to the head of bioethics at Tuskegee who said, you have to have church leaders out there that are not going to listen to doctors.
Mhm.
I think I'm a Boston Children's Health Physicians, and I think the question of resilience is what we're really asking about, is how do we create a system that's more resilient to things that are thrown at us now and in the future. And I think we're on to something about the messaging and the trust factor. And in the past, a lot of what we did is had the government agencies be behind us, promoting us as the authorities and being the messenger. And I remember growing up in the German measles, pandemic, when you just had a 2-second black and white commercial and everybody got the German measles vaccine. The kids came home and they trusted the system and the government backed that up. It's amazing with all the technology, social media and stuff we have today, we can't do a black and white commercial, decades ago. And I think what we really need to do is think about how we regain the trust, how we may have lost the trust in certain communities, how we regain that trust, put ourselves back as the messengers that raise up the community. The way I think we get resilience is we educate our society. We don't keep this information locked tight. We don't release it, piecemeal, but we bring them along on the journey now, so that they're sharing it, and that's how we counter all the stuff that gets thrown at them from other directions. We become the trusted source, and I think there were a lot of reasons we were not, but I don't see any other answer. It's the weakest link. You can have the best technology, the best vaccines and everything, but if that last link of linking us to the community is gone, all that is for naught.
Completely agree, yeah. Scott?
Yeah, this is such an important conversation to have, but this isn't the problem with trust, just this pandemic. And it's not just against medicine. There's been a multi-year war on scientific expertise in education, expertise in climate change, expertise in healthcare. And it's not just the past 3 years. It's, this is something that has been going on for a while, but really has crescendoed. So first we need to recognize that. And during the pandemic, the state health officers, we would have calls on Tuesdays and on Fridays, and really stressful positions. And we were all in this together. And one of my colleagues said, I just got off phone call with the superintendents in my state, and I lectured them. I told them, I said, it is your fault for not teaching students to respect expertise at one level. Because we are having individuals, you look at Google, what you learn on Google is valuable. It's what you learn from your biology teacher who has, who's taken years of education on this. So it's a really complicated situation that we're in. And getting to the point that you made, how do we get back to the trusted source? And that's something we're gonna have to all do together. We talk to your physicians about it, but how do we enable physicians to do that? We need to have simple, clear, concise, consistent messaging to have individuals do this. And then we also think that all of us physicians, we all think the same way. Well, not all healthcare providers are vaccinated. Some healthcare providers will provide medications that aren't thought to be mainstream as well. So, so this is a really complex issue that really goes beyond medicine, and we're gonna have to put our heads together on how to do this. And talk about some of the great things that are happening at Brown, particularly in the School of Public Health. So in terms of pandemic preparedness, Dr. Jha, before he went to the White House, recruited Jennifer Nuzzo from Johns Hopkins to lead a pandemic preparedness institute, and then also recruited one of the leading world experts in misinformation, Dr. Claire Wardle. So, these are the kinds of things. I mean, you're all here with some kind of Brown allegiance, and should be very proud of that and proud of the fact that these are things that hard issues that we're addressing.
Great answer. Liz, in terms of misinformation, bring the digital world into this for me, because you know what? People don't just go to their primary care doctor anymore, and they don't, to the gentleman's point, to Scott's point, looking for clear messaging, but everybody's Googling everywhere.
Mm-hmm.
How do you, and on the internet or on social
Yeah.
media, you see some idiot saying,
Right.
take ivermectin, right?
Right.
So,
Yeah, here's the issue. Information is now decentralized, right? In the past, you might have turned on your TV and you saw your Surgeon General on the TV and you got a 2-minute news snippet, and that's where you got your news. So then you go out and get your vaccine. But now anyone can sign up for a social media account and they can make a statement, and they don't necessarily need to back it up. And maybe there's a problem with public education. Maybe we haven't educated our kids enough to understand like what trusted sources are. But we've also really decentralized how we get our medical information. And I think social media can be a force of good. There's some real terrific experts, including, at our school, Dr. Megan Raney as an example, Dr. Jha, who are really fantastic communicators. But I'd say in general, as a
or
physician,
Eric Topol, who's amazing.
Eric Topol, another great example. In general, we do not get that kind of training in medical school, or even provide that to our scientists. We're starting to change that. We have some new MPH programs here where there's a real focus on leadership and communication. That's another lesson learned through the pandemic. We need public health officials to really understand how to connect to people. But just one more comment on that other topic of how do we build trust. The average person out there, they're making 30 grand a year. The median salary somewhere around that in Rhode Island, and they're seeing these huge differences between how they live and how the 1% lives, and how our government treats the 1%. And the average person is not getting the child care that they need. They're not getting the elder care that they need. And it's like, well, obviously there's mistrust, because they can't even get their basic needs met. They're working 2 full-time jobs, and they're coming to me in the emergency department in the middle of the night because they can't miss a single day of work, because then they can't feed their kids.
Great point. You have to add that if the
Yeah.
school's closed, the kid is home with them.
Right.
They don't
And
have a nanny.
the
So-
amount of neglect we've seen with schools closed, because you know what, that 10-year-old kid that's at home now is all of a sudden is the babysitter for the 2-year-old, for the 4-year-old, for the baby, because the parents need to work to put food on the table, and there's no other option for them. They're supposed to be in quarantine, but no one's delivering food to their house. Like, obviously there's mistrust.
So yeah, and I think during the pandemic, our primary care offices were shut down, right? They were, you could only get an appointment online or on through telehealth. So people couldn't come into the office and say, what do you think is going on, and what should I do, and is the vaccine safe for me? So people couldn't access that. So they were going to, of course, TV and the social media. So I think that was a big challenge for like a big part of the year, at least one whole year, maybe, and probably more than that, probably 2 years. I think that, I was involved with remdesivir studies in the hospitals. I was also involved with the vaccine trial, Novavax. And so I was very motivated to, speak to the media. I wanted people to know that this is what we were doing here in Rhode Island. So every time anybody asked me for an interview, I basically said yes. I felt that it was my duty and responsibility to say what was going on and answer those questions. And at least, and I did many local interviews, radio and TV, with the health reporter here, Barbara Moore Silva, who's very informed. And so I think that was my contribution, really, to try to get the information out there, let people know what was going on.
So everyone on this panel is either a public health expert or an infectious disease expert, and this is who obviously people should be listening to, but are not. Scott, follow-up thoughts on this?
Can I ask a question, please?
Yeah, hang on.
I'd like to
Go ahead,
hear some thought on what your thoughts are on the politicians that purposely denigrate education and science for political gains. The folks that maybe knowingly or maybe unknowingly try to say, that the people that are the educated elite are against us, and they're trying to use science as a divisive tool to win political points.
So this is something I've written a lot about, but I'm going to ask Scott to answer this. The politicization of the pandemic has been huge, and it's undermined the science at every step. And you want to make a comment on why or the impact it's had? I'll answer
Since
that,
you
by the
made
way.
it a yes or no question, the answer is no.
Before you answer it, I'll say something very optimistic, by the way. I talked to David Oshinsky, our top medical historian at NYU, and I said, is this pandemic going to be remembered in terms of the political wars that went on over everything? He said, no, it's going to be remembered in terms of the great medical technology.
Yeah, it's a really complicated situation. We have a very polarized country that's moving farther and farther apart. We have less community than we ever had before, moving into so-called tribalism. There's some wonderful books and things like that have been written about this. So, it really comes down to the fact: how do we get ourselves together as a society back together to be able to address those issues, rather than having one group trying to focus on, one group of individuals I need to reach out to get elected versus another group reaching out to others. We have to realize that we're all in this together. It's unfortunate that the pandemic has hit different groups in different ways. Maybe as we reflect on this, maybe that will say there could have been a different path forward out of this, and we wouldn't have lost 1 million Americans, where the sad milestone that was recently crossed.
Hi, I can project, so I know, so I am a senior. I'm graduating this year.
Congratulations.
So I spent 2 years of my college career locked away in a 100 square foot room. And we were all exceptionally cautious. I saw, I think, probably 5 people over the course of both of those 2 years. For the first time in those 2 years, we took off our masks in class. I was also devastated to learn that our commencement weekend was going to be masked. That was just a really sad thing for me. But my question is about the fact that in a community like Brown, where we have a 99% student and faculty vaccination rate, there was a lot of internet pushback from very small groups of people saying that people who wanted to return to some sense of normalcy were selfish and hateful, and even going so far as to say they didn't deserve to be at Brown if they were going to hold views like that. And as a person who was very cautious and who followed all the rules, and we've made it this far, what is your advice for balancing that desire, that need for normalcy with appropriate precaution, appropriate sensitivity?
Great question.
In a highly vaccinated community?
Great question. Everybody take a shot at that. Compare Florida to Rhode Island, please.
I have 4 kids, and they spent a large part of the pandemic also at home. And the reality is we are dealing with not only a COVID crisis, we're dealing with a mental health crisis too. And we are seeing record numbers of adolescents and children and young adults like you with anxiety, with suicidalism, and we don't have the resources to meet that mental health crisis. And what we need to really invest in is prevention. And like, what is the response to those people? I think it's really hard to counteract that hate with kindness, but they might be driven, to be very pro-mask because of their own personal medical situation, and I try to have grace with those people. We see those people in the hospital all the time that are like really polarized and have really strong opinions, and often when you peel back the layers, it's because they have a tremendous fear, anxiety, have had a bad experience. And I think one of the things you'll learn as you do your medical training now is that it's not always what it appears. And having, I think, grace and kindness and understanding that, people have different backgrounds and different vulnerabilities is always the best approach. But we really, really need to kick into high gear about the mental health crisis, because keeping people isolated and lonely is having major repercussions in our society.
Yeah.
By the way, one thing's for sure, when you're on the wards, you're not going to be doing it remotely, I'll tell you that. Yeah.
Actually, can I respond to
Go
that
ahead.
also? The Aaron Carroll's a fellow pediatrician out of Indiana University. He wrote this really nice piece in the New York Times, I think it was probably in January, saying we have to stop thinking about this pandemic as physicians. We have to think more from a public health lens. So we really have to focus on society. The other point he said is that there's no such thing as totally safe or totally unsafe, and it is a balance. So in the fall of 2020, Florida, like many of the other southern states, opened up their schools, right? And we did it safely. But a lot of stuff went on behind the scenes how that happened. So we pushed out millions of masks to schools. We had contact tracers in every school. We set up testing so people could be tested
Right.
that day in school. So, and then for the universities, I had regular meetings with the board of governors and all the university presidents talking about what are the things that we can put in place so we can balance educational activities with safety. And again, we don't know all the answers to these types of things. So it's a balance which individuals really have to look at. But there are ways to do things to keep things going, business, society, schools, in a safe, effective way. But we have to recognize that there's a balance with this. Nothing is totally safe, nothing is totally unsafe.
And Scott, actually, there were studies that backed up what you were doing. Danny Benjamin's studies from Duke looked at schools that had mitigating strategies in place and stayed open. Because if kids were out of school, they were spreading COVID in the community at a greater rate than if they were in a controlled environment.
Yeah, and they were more likely to get it in the community than in schools.
I just also want to take a second to validate your feeling that, like, I don't want a mask in here. That is like a valid feeling that I've worked really hard for 2 years. I've done everything right. I've gotten vaccinated. And I think, yes, you deserve to be with your friends and to be maskless and to enjoy this moment. There's been a lot of delayed gratification.
Just for the pictures.
Right, even just for the pictures.
You're going to be a great doctor, I can tell.
Yes, I have a question about Rhode Island. So it seemed to me that Rhode Island had a pretty decent response to the pandemic, but our death rate was so high. And I was just wondering, is that just because it hit us early, or was there something else going on?
Well,
Or am I wrong?
I think, I mean, we have an older population here in Rhode Island, so it could be that. And, I think that the public health response was fantastic. We had Nicole Alexander Scott and the governor, Gina Raimondo. They were out there all the time and really holding 1 hour conference calls, I don't know, daily. I mean, it was really amazing.
And not to mention the prison system here is terrific at public health control.
But they had to speak up. They
Right.
had to say, hey, we need the vaccines for the prisoners. So, so that was really important too. So, I think that we were out there number one with cases, with, hospitalizations, but, we're a small state. We have most of the population is in Providence. I think that was one of the explanations, was that most people we were all in Providence. So the numbers look bad, even though because we're a small state.
And if you look at our urban core, there's high rates of poverty. There's high rates of Latinos that are living, 8 family members to a small apartment. So in the beginning, when I was working in the emergency department, it was a lot of folks that were in this congregate housing, and Black, Hispanic folks that were in housing that was really, really dense.
Right, no way to quarantine
That couldn't
or isolate.
telecommute.
Yeah.
Yes,
Hi, can you hear me?
yes.
I'm an emergency physician here in the Brown community, and I was drawn to the topic, the title of this session, particularly some of the charged words like war and undermine and politics. And my question has to do with the differentiation between battling misinformation, of which your panel has outlined some thoughtful strategies. You made some comments earlier about trying to understand the other, the perspectives of others, community leaders, persistence, I'm curious about the concept of disinformation, which is more the active manipulation of facts rather than the propagation of incorrect information. And do you believe that those same strategies apply when combating disinformation? And what role can physicians play in doing that? In battling disinformation?
I'm going to take a quick stab at this before I give it to them. You know, I was very proud of Neil Young because Neil Young had polio and Joni Mitchell had polio, and he didn't like that Joe Rogan was pushing this BS, and so he said, "It's him or me. I'm gonna take my music off of Spotify if you continue to give him a platform." That's one way to fight disinformation. I'm a big Neil Young fan anyway, but.
I think there's a technology fix too. So one of the things that we're seeing early on in the pandemic is that posts from uninformed people that were like maybe even Russian bots, who knows, that were trying to purposely provide disinformation. Posts that were in English language, those were taken down far earlier than posts that were in Spanish or other posts. And so, finding ways either through our regulatory system or technologically to spot those areas of disinformation and just taking them, not providing them with a platform, that is something that we haven't invested in enough. And I think we need to really hold those leaders of Facebook and Twitter and the other social media companies accountable to do that, because that has been a huge source of disinformation.
Although, just to push back for a second, I don't know we have to do that by censorship. That's not American. So there's got to be a way to do it. I don't know the answer, but I don't like the censorship part. Like, I like the idea of people. I like free speech, but I don't like disinformation. So I'm kind of.
I guess I guess in addition to trying to promote the good information and the important medical information, to always say like, well, this information is wrong. Maybe we just have to keep saying that and not ignore it as like, oh, that's fringe, or that's nobody believes that. I think maybe that's something we can do when we get our messages out is.
We have to listen to someone like Karen, who knows the field, who studies RNA viruses. I mean.
Besides the COVID pandemic, can you talk about other areas of medicine where you feel like there's misinformation and you have sense underlying the expertise?
COVID was a big one.
Yeah. I mean, I think we're still not doing a good enough job of like elevating folks' lived experience, where there's a movement now in geriatric research to really involve the caregivers and kind of these informal or formal caregivers. I think that there has been the sense that physicians in medicine has not listened enough to the voice of diverse people that play an important role in medicine.
I mean, other vaccines, people are still, fighting vaccines in general. So, we all have patients that just refuse all vaccines. So, but they might also refuse quitting smoking. So I just keep on asking them every visit, like, hey, would you like this? This might be good for you because you have, you had pneumonia recently. Maybe you want to get the pneumonia vaccine. So.
Yeah, I think those of us in medicine, you going into medicine, you in medicine, we have to remake advocacy. I used to be the pediatric department chair's representative to the Pediatric Policy Council. And when the issue would come up, we'd make a form letter that sent your congressman, sent your representative. That's not advocacy anymore. Things sit in email boxes like this. And, when I lived in Massachusetts, when Tip O'Meara was our congressman, he'd say, politics is local. It's the same thing with public health. It's all grassroots. It's all local. So things are different now. So like a colleague to my left, she's on the Providence School Board. Those of us in medicine, we have to get involved with different organizations, faith-based organizations, working with different departments of health, working with school boards, working, health equity zones. This is where we're going to be able to have our impact, because it's really hard for us to fight with these social media wars. You started off talking about, people think it changes genetic information. Those information is out there. In terms of when studies look at the Twitter wars, the Facebook wars, it's clear we're being outnumbered there. But there are different ways that we can do, and people in the medical community, people in public health, deep down, they are trusted. So we really have to change the way we are doing things to really get to more grassroots involvement, is my opinion.
Liz, final thing, and this is going to blow you away because I love his point about outside of COVID. Let's look for a second at gun violence in schools. Don't you think isn't it relevant that someone who can't drink can buy a gun? So is gun violence something that should be in the public health arena and discussed?
I think one of our largest tragedies as a country has been our lack of funding of gun violence research. And it's heartbreaking as a parent, as a school board member, that we have not put enough protections in place for our children and for our teachers and for the staff in those buildings. And just like I've been having weekly meetings about masks, I've been having weekly meetings about security systems. But you know what? It's not the answer, the public health answer to gun violence is not installing $1 million security systems in our schools. It's providing the mental health support to our youth. It's funding gun violence research. It's allowing experts like, Dr. Megan Rainey, she's a Dr. Emmy Betts, allowing experts to tell their experience, working in these ERs. We should be allowed as physicians, I think, to provide information to our patients about how they can secure their guns. I think we've just really been lacking in having like a public health conversation about guns because it's such a polarized topic.
Thanks, everybody. Thank you. Thanks, great panel. Thank you.